Okay, we get started. Good evening, everyone. Thank you, everyone, for joining this teaching session organized jointly by ORUK and FRCS Mentor Group. As you know, the main focus of our teaching program is preparing candidates for the FRCS examination. We have the pleasure of having Mr. Paul Marshall as our guest tonight. Mr. Marshall is a consultant orthopedic surgeon, a university hospital in Morecambe Bay, and he is the associate medical director there. And what makes him a perfect guest tonight is that he is an ex-FRCS examiner. So we were just talking about it before we went on air. Being ex-examiner, that means he has lots of experience.
Firas, I think you're on mute.
Sorry, someone muted me. So I'll go back. I'll restart.
Yeah, thank you. Sorry about that.
Okay, I think someone muted me by accident. Well, good evening, everyone. Welcome to this FRCS teaching session organized jointly by the ORUK and FRCS Mentor Group. Our guest tonight is Mr. Paul Marshall. We are very pleased that he's with us tonight. He is a consultant orthopedic surgeon in the University Hospital in Morecambe Bay. He's also the associate medical director there. But what we are very interested in tonight is that he is an ex-FRCS examiner. He has he's been examiner for many years. He's accumulated a lot of experience and wisdom that he's gonna speak to us about it this evening. So his main lecture tonight is about, it's a little bit of interactive lecture, and he will tell us about the best approach for the exam and how the examiners look at the candidates and what they're looking for in a candidate, and how can a candidate impress an examiner and score high. And we're talking before we went live, that's his recommendation was generally that we should aim for the top score in any station we do. So we're very pleased that we have Mr. Marshall tonight, and I'm certain that each one of us will learn a lot from him. So I'm Firas Arnaout. I'm representing the FRCS Mentor Group, and I have with me other mentors from our large group, and we have Shwan and Joe helping us tonight, and also we have the team from ORUK, the educational team from ORUK, Imogen and Hannah. So the session basically will include this talk from Mr. Marshall. There will be a little bit of interaction, and there will be an opportunity for some viva and some questioning as well, and some feedback. So if those who are interested, please express your interest, and Hannah will be taking names. We understand that this could be stressful for any candidate to speak in front of 130 people. So we will take that into account, and we understand this stressful situation. We all have been there, and we all respect whoever comes forward. Just after the session, there will be, as usual, some viva practice, and CPD certificates will be available if you contact the ORUK educational team. If you miss any part of this lecture, don't panic. We are recording it, and with the permission of Mr. Marshall, we'll be able to share that later on. So without any further ado, I will leave you with Mr. Paul Marshall.
Thank you very much, Firas. It is it's a pleasure to come and talk to you this evening. I don't know whether Nikki Walsh is here. Nikki is an associate specialist who works with myself in Lancaster. And we've worked for many years, and I know that Nikki is encouraged me to participate to the group, which I got an email yesterday saying, your speaker's not here, so can I help? And yes, I'm really pleased to be here. I'm going to just give a little bit of a talk about what I think is helpful for you to know approaching it as an examinee. So I examined in trauma and pediatric orthopedics for 5 years, and I was probably 5 years ago when I stopped. So things may have changed a little bit, but there's still the same emphasis on scoring the candidates to give them a mark. I mean, you've all come this far in your medical careers, you all sort of know it's a little bit of a game. You know that it's not quite the same as clinical practice, and particularly the short cases, and probably less so the vivas, where it's just not something that you do day to day. You never approach a patient and, examine this patient's shoulder, examine this patient's brachial plexus without taking a history. It's very sort of a foreign experience, especially with somebody watching you. And I think the best way to do well at that, as you probably already know, is to practice it with colleagues, pretend it's an examination, and it becomes more and more sort of ingrained in how to do it. So I'll talk a little bit about give you hopefully some helpful tips about the exam. If we then we'll probably open it up to questions, and if you've had experience of the exam and you want to share that is fine with me. If you've got particular questions, specific questions around orthopedics, trauma, pediatrics, then we can open that up to the group and discuss that. But essentially, the examiner, as I said, is trying to give you a score. He's got 5 minutes in the viva, pediatric viva, 15 minutes, and that's 3 questions, and you score each question. So each question lasts 5 minutes, and that's not a very long period of time really to sort of get to the bottom of a topic. And it's certainly very difficult to test what the examiners like to call higher order thinking. And higher order thinking, I think, comes from sort of a human factors background, where you are sort of thrown things which are a bit unusual. And I think one of the ways of sort of thinking about it is airline pilots, when they're sort of got nothing to do up there, up in the sky, they sort of play human factors games. They play what if games. What if this happens? What if that engine fails? What if this happens? What if we have this incident? And examiners can sometimes bring that in. What if this happens? And that is their way of trying to test your higher order thinking, and how you can think on the spot. But essentially, each section, each sort of question is scored, and most candidates will get a 5, a 6, or a 7. And a 5 is a borderline fail, and a 6 is a borderline pass, and a 7 is a good pass. Okay, and occasionally you may get an 8 if you've got a really excellent answer, and a 4 is a sort of bad fail. It's not to say it's irredeemable, because if you score well in other sections, you can make it up, but you don't want to score a 4. So to try and avoid scoring a 4, the examiner wants to make sure that you're safe. So the first part of the question will be, is this person safe? Is he safe to be a consultant trauma orthopedic surgeon on day 1? Okay. So the way they will format their questions is that the first part of it usually is, how can I test if this patient is safe? Okay. And then once they've established that the candidate can give a safe answer, is safe to practice, then they'll sort of rack up the questions a little bit more and say, well, yeah, he's safe, but has he got the knowledge and the sort of experience, I suppose, to pass? And then if he's got that level of skill, is he a good pass? Can I ask him a bit more of a difficult question, just to see if he can answer that, so we can get him into a good pass? So there's a stepwise progression, really. So every question starts with that stepwise progression, particularly the first question that you get asked in the viva. If you answer the first question well, I'm sure it does have an effect on the examiner to think, well, this is a good candidate and he's doing well. So the first question is key, but I think you probably know that already. It's with any sort of consultation, any sort of interface between people. The first 7 seconds are really important. So yes, you can walk in and the examiner may or may not offer you their hand to shake. And obviously in COVID times, we can't do that, but do the appropriate thing. Say hello. The examiner should introduce themselves and they'll check your identity. So the first part of the question is a sort of a settling question. Examiners are sort of vetted, so we don't like examiners who are sort of a bit maverick, a bit difficult, who throw sort of googlies, if you like, to try and catch you out, especially early on in the sort of in the viva. So you might start in sort of pediatrics where supracondylar fractures of the humerus. You sort of expect you might get that question, and you might say, well, you're called to the emergency department. They tell you you've got a child with a supracondylar fracture. He's fallen out of a tree. He's 8 years old. And then I sort of ask, well, what do you want to know down the phone? I mean, that's not a difficult question. What do you want to know from the emergency department about this child? Sort of, what's the neurovascular status? When did they eat or drink? And then what are you going to do next? So I want to hear that, yeah, I'm going to go down straight away and see this child with a supracondylar fracture. Okay, well, that's all good. That's pretty easy. And then how are you going to assess the neurovascular status? What are you going to do to assess the neurovascular status? So it's just getting a little bit more sort of involved, if you like. I want to see that the candidate can assess radial, median, ulnar nerves. Okay, so that does take about a minute. And then we sort of move on. And my general approach after that is to sort of, you're taking this child to theatre, okay? And what I probably don't want is a lot of preamble about getting everything ready, etc. So we want to sort of, if the examiner asks you a specific question, answer the question, okay? So you've got the child in theatre, and how are you going to reduce the fracture, okay? So if the examiner's given you a sort of fairly specific question to answer, do your best to answer the question, okay? And then the examiner might want to interrupt you. If you get a chance to talk, it's probably a good idea to talk. And say, particularly if you can show confidence in the management of a condition. So one question I might ask is, have you been involved with these cases of this nature? And you may not have had that much involvement. Hopefully with supracondylar fractures, you've got a reasonable amount of experience. But there may be cases, for instance, slipped epiphysis, where you may not have had that much experience, but you are expected as a day one consultant to be able to manage that condition. So yes, I have had experience of managing this condition. So it then progresses as to essentially how are you going to stabilize this fracture? Are you going to fix it with wires? What wires are you going to use? And if you can sort of, whilst the examiner sort of guiding you along, try and rack your brain for anything that you can about the literature or about BOST guidelines, okay? Because if you can bring those in to the discussion at some point, even if you don't get it completely right, it stands you in good stead. Because one of the things that differentiates a sort of a borderline pass from a good pass, and as I say, you want to aim for a good pass rather than a borderline pass for every question, is knowledge and application of the literature. So there are certain sort of key papers, if you like, and even if you can't remember the authors, you can put into the discussion, well, the BOST guidelines say this, or there's a good paper that I've read recently which says this. And the examiner might take you up on that and say, well, where did you read that? What did you think of the paper? And you might then say, well, I'm sorry, I can only remember the abstract. That was the message that I got from the paper, which is okay. You know, you've done your best. You've sort of put something forward, and it is good to be able to sort of the recent literature, Bone and Joint Journal over the last sort of couple of years, papers that have been published recently in that journal or other highly valued journals will be things to contribute. So try and score for a 7. You never know quite what the examiner is going to give you. Often you walk out thinking, I've done terrible, I didn't answer that question very well. But what you think and what the examiner thinks is not the same. And then once you've got 5 minutes is up, you've got to start again. So it's like, I guess, a bit like cricket in the sense, the examiner bowls your ball and you can sort of see where it's going to go, supracondylar fractures, slip epiphysis, infection, tumor. Once that's been bowled to you, so to speak, think in the back of your mind, what do I know about the literature around this topic? What can I sort of bring into the discussion in, say, 2 minutes time that will convince the examiner that I've got more than just a borderline knowledge, that will convince the examiner that that my destiny is a good pass. So those are the sort of fairly simple things I would sort of ask you to focus on. I mean, you may say that's fairly obvious, and I guess it is a little bit obvious, but the examiner is trying to give you a number and you want to get a good number from the examiner. So I think that's probably the main things I wanted to say. So we probably open things up. I don't know whether I've got any questions. I'm going to have a look here.
Yes, Mr. Marshall. Yeah, we got, I think that was wonderful advice, really, and really reaffirms that general approach. That's I like that you advised candidates to have a sort of a timeline, isn't it? And I noticed that within 1 minute, you said we're starting on the theater questions.
Yes.
Because some candidates have that tendency to ramble along and keep talking about assessing neurovascular and consenting and preparing theaters and stuff. They find themselves into the 4th minute and they haven't really answered the question yet.
Yeah,
So,
the good examiner, yeah, thanks Firas. A good examiner will have a way of sort of stopping you. I'll do the consent, and et cetera, and it's all good to do that, and I'll examine the patient according to ATLS protocol, which is a good thing to say, but you've got to think in the back of my mind, where is this going? This is a question about supracondylar fractures of the humerus, and you've got to sort of rack your brain for any sort of extra little bit of information about that topic. And sometimes it takes a while in the pressure of an exam to bring that information forwards. So my suggestion is, once you know what this is about, think, what do I know? What extra do I know about this topic? And then towards the end of the 5 minutes, minute 4, you might be able to say, well, there's some literature on this. And I remember reading a paper about this, and this was the message from the paper. And that gives the examiner a good impression, because at the end of the sort of 5 minutes, you've told him, a little bit about the literature. And he may think, well, they knew a little bit, but they didn't know very much. But it might be just enough to get you up into a 7 from a 6. So that's sort of where I'm coming from for us. Yeah. So yeah, the good examiner will stop you from waffling on. But if you think, well, I know this, I really know this, then keep talking. They will let you talk. Sometimes if you make an error, they will pick you up, and sometimes they won't. But if you know it, keep talking, I think. But always be guided by their sort of eye contact and whether they want you to stop. Okay.
I think you just answered the question that was asked by one of the candidates in our audience. Shinil Koshi, he's asked, if you know the subject very well and you know or can sense where this is going, shall we just keep going? As a candidate, just keep talking all the time? Or, let's say examiner says, how will you examine this patient? Just examine and then move on with the topic, or just examine and wait for more questions?
Yeah, in the short cases, the examination, it is okay to sort of seek some clarification, but the examiners are really fairly specific. Examine this patient's shoulder, and you have to have a mechanism for examining the shoulder. I think it's permissible in the short cases. I think it's permissible just to ask the patient, do you have any discomfort or tenderness in your shoulder? Before I examine you, I'd like to know whether you've got any pain, and could you show me where the pain is? I think that is a nice thing to ask.
Yeah.
And I don't think the examiner is going to sort of stop you from saying that, because, even though it's a bit of a theater, it shows that you've got, appropriate concern for the patient before you examine them. So that, I think, is a good thing to do in the short cases. But they are very specific. Examine this patient's shoulder, this knee. They may want to sort of be more specific, like examine this knee for clinical instability, examine this shoulder for evidence of rotator cuff tear or impingement. So if they are specific, then you need to sort of tailor your examination to what the examiner is asking for. I don't think you might be able to comment on this, Firas, but I'm quite happy for candidates to talk as they're examining. And some people don't like that. I sort of encourage, that would be my default, to talk as you're examining. It sort of helps you in your own thought process as well. It gives the examiner something to listen to as well as to watch, and they might then sort of just guide you a little bit or interrupt you if you're talking as you go along. So I don't know whether you've got any views on that yourself, Firas, about should you talk when you're examining a patient?
Yeah, I think I totally agree with you, because the examiners sometimes, in the heat of the moment, they don't know what exactly the candidate is trying to examine. It could be a little bit confusing what they are trying to palpate here, or what test they are doing. So at least if they talk, as long as they don't over talk it, and as long as it's just of professionally saying, well, I'm putting the knee in a 20 degrees, doing Lachman test, I'm doing, just gently, they don't have, because they also don't want to irritate the examiners, or insult the intelligence of the examiner. So I think definitely talk, but keep it to the minimum. That's the examiner will need to know. I mean, if you doing Trendelenburg test, for example, you don't have to tell examiner exactly each step you're doing. I'm putting my hand on the pelvis now, and now I'm asking the patient. You don't have to do. These are very obvious things, but you could just talk to them about the salient points, how you're assessing the abductor, you're looking for pelvic tilt, this kind of thing. So it's a game. It just comes with practice. But I think we've got to talk. If you just someone goes silently and just goes and examine, I think that's be very difficult for any examiner to score them.
Yeah, there is also a catch. I'm sorry if you don't. There is a danger that you are going to describe the examination without actually performing the examination correctly. So anyone that's planning to speak in the exam, which is not a bad thing, I agree with it, because it gives information as you're doing the examination. So your findings, but also what are the key points in your examination. But practice doing that in real life as well, because what tends to happen is you tend to stop and describe what you're doing before you do it. And that I've noticed that irritates examiners.
Yes.
And irritates me when I'm trying to examine someone when they're practice virus.
Yeah, you don't want this to slow you down. If you're talking, if you have to stop to speak, that's also will be wrong. You'll be using a lot of time. So you have to talk as you go, not losing time, obviously, and it just comes with practice.
It does. Exactly. It does come with practice. It's not something that you do in a clinic. You don't talk to the wall whilst you're examining a patient in clinic. You maybe talk to the patient. You maybe get a bit more of the history, but you don't tell them I'm doing this is a Trendelenburg. Now I'm doing a Trendelenburg test, and it is a very, it's alien sort of. It's alien to clinical practice, as you know. I mean, we've all come, we've all done these sort of clinical exams in the past, but I do think a little bit of talking can be helpful. And I think it is also very good practice to sort of, I think it's good to introduce yourself to the patient. That's a nice thing to do. It doesn't take a minute to do that. And I think it's also good to ask them if they've got any particular discomfort in the area where you're going to examine, and say that you examine it very gently, and please tell me if it is uncomfortable for you. So I think is a reasonable, the examiner, don't waste a lot of time with that, because the examiners, you've only got a few minutes to do the examination, but I think it is quite a good thing to do. But again, Firas, have you got views on that, or do you just get on with the examination?
I think, yeah, just talk, I think, but you have to sort of not over talk it really. Basically, for example, if you're doing, examining the arc of movements and you're putting the arm in an external rotation, you don't have to say, I'm doing external rotation.
Sure.
I mean, it is very obvious. So you just say external rotation is so and so, internal rotation is so and so. You don't have to tell, well, I'm doing external. It becomes too basic and like a medical student kind of.
Indeed, yeah. You want to make sure that you're pitching it at the level that you are sort of, at FRCS trauma and orth. So you could sort of say supraspinatus, infraspinatus, subscapularis, in terms of your assessment of the rotator cuff. I think there's a tendency to go away from eponymous names now, isn't there, in the exam? But all the examiners still know the eponymous names. So if you know the eponymous names, then I would volunteer those names. It won't do you any harm.
And it's very good to hear from you.
Sorry. So the point out to the guys who are watching, yes, we are talking about examinations, and I know that during COVID time, we're not having any patients in the exam, and that the patient is actually going to be the examiner, but you're still not allowed to touch the examiner because of COVID restrictions. We appreciate that, but we are talking about normal times, and there are people who are preparing for the exam next year, and we're hoping next year.
Yeah. I mean, I'm not actually, you would know how the FRCS trauma and orth exam has sort of is going ahead with COVID restrictions, isn't it? So there are sort of this sort of these dark days of COVID, things are different, but things will get back to normal. I think I think.
And ironically, the guys who were practicing talking while they're doing the examinations will probably do better, because what the examiners will ask you to do is describe the examination to them.
Yes.
Or demonstrate on yourself, for example, how you're going to place your hand where and so on.
Yes, it must be very difficult examining somebody, doing on a screen like this. Really, very, very difficult.
So, Mr. Marshall, I've really liked when we discussing about how to kind of score high mark by quoting literature, and you passed on a very, very important message here. That's, if you've only read the abstract, you could say that, isn't it? You could definitely.
Yeah, for me, you can say that. I mean, in the heat of the moment, and it is very difficult to recall. I mean, everybody. It's such a big syllabus, lots to learn. But if you can just remember something from the literature, or if you've read through the Bone and Joint Journal for the last 2 or 3 years, you can say, well, I remember reading an article within the Bone and Joint Journal within the last 2 or 3 years, because that, if that's the journal that you've read, then you can put that forward. And the message from the paper was this. And I think the examiner knows that you probably haven't, you can't critique the method of all papers and be able to discuss them, but I would put it forward that you've read the paper and this was the message of the paper. So it's the message. That does come across quite well, that you're looking at the literature and you're saying, well, what's the message in this for me? I mean, we often sort of, if in our own areas of expertise, we sort of finally critique papers, but if we're just trying to sort of keep ourselves up to date, then we're looking for the message in the paper. And I think if you give that message to the examiner, it shows that you're reading the general literature in a sort of an intelligent way.
I totally agree with this. I think there are a little bit of mixed messages here. Some candidates worry that if they quote literature, they might be quizzed on a paper, so that the examiner can tell them, okay, you're quoting this paper, so tell me how many patients recruited, what's their statistical analysis method they use, how reliable is this paper you are quoting. They get worked up about this. So I don't know, my thought, I think if that paper is just supports the general understanding and it's not controversial and does not contradict anything that's common practice, then you are very unlikely to be challenged. But if you suddenly say this paper says you can cuff in a wound and there will be no infection, then of course the examiner is going to ask you about it in details. But I don't know what your views on that, and because we had a lot of questions about this, how the best way of quoting literature, and you know, people want to score high.
It is difficult, but I would sort of encourage you to do it, because I think you're more likely to sort of do yourself a favor than to sort of dig yourself a hole. And the examiners, you know, maybe they've wrote the paper, or they know somebody who wrote the paper. It may be their area of expertise, and they may want to sort of just show you how knowledgeable they are about the paper, but they're not supposed to do that. They're there to sort of assess you, the candidate. So I think it's unlikely that you will get that sort of, they'll probe a little bit. It's this sort of, what's the depth of knowledge here? So yeah, okay, well, tell me a little bit more about the paper. And all you can say then is, well, I'm sorry, I just remember the message. Yeah. Or if you can remember a little bit more, you know, just give a little bit more that you can do without sort of digging the hole, I suppose. You've got to be guided by the signals that you're getting from the examiner. But it is okay to say, you know, I'm sorry, but that, you know, I remember the message from the paper, but I don't remember the details of the method and the discussion. And I think that's okay. You know, I would sort of, I would support that. I don't know whether.
I definitely think it's worth quoting literature, but you need to quote it correctly. So where examiners, where I have always picked on someone is when they've misrepresented the literature or misunderstood it.
And that's when you could dig yourself a hole, isn't it? That's when the examiner, that's it. The examiner will take you into that direction and start.
So I would, with that in mind, you know, every paper that you read in preparation for the exam, ask yourself, what is the message from this paper? You know, I might have to sort of I might have to sort of recall this in an exam situation. You know, what can I tell the examiner about, you know, what is the message for me or for my clinical practice from this paper? And you get that from the abstract, really. So that's, you know, in the days before the exam, you know, before the part 2 comes around, sort of glancing back through the journals, looking at the abstracts, and if you find something that catches your eye and you're interested in it, then, you know, by all means sort of follow that up and maybe Google it or look on author bullets and just see where it takes you, because sometimes that sort of inquiring helps you to remember things. If you let your sort of mind, your natural tendency to inquire into things, that often helps to sort of secure it in your memory a little bit. But yes, it's the message. What is the message in this paper? You don't have to know where it comes from or who the authors are, but the message is what I would encourage you to put forward in the exam.
Thank you, Mr. Marshall. We have a few questions also coming with the people. So Darren asked, is from your experience as examiner, what do you think the main reason that people, candidates, unfortunately fail the exam? And is there any particular irritating traits that you noticed in the candidates that you think they could be avoided?
Okay, I think sometimes you get a feeling that somebody hasn't really done this procedure, or they haven't really seen this sort of problem. And it can be difficult depending upon, you know, the training that you've done. And if you haven't done a pediatric job, or if you haven't done a hand job, then you're sort of at a disadvantage, I suppose. You're at a disadvantage. But to those people who haven't sort of, you know, I haven't seen this particular procedure, but these are the principles of management. So I think if you aren't confident in an area, then the examiner sort of gets a feeling for that fairly quickly. They get that sort of vibe, and I suppose to sort of keep yourself going. We've all been in those sort of situations where we're not particularly confident in a topic, and the examiner is sort of asking us more and more questions, and we're wishing that the earth would open up. But I think you can come back to a situation. You can. This is another little point, actually, slight sidetrack. But they often ask you a difficult question, and you think, well, there's more than one answer to this question. So you can say, well, there are two it's not a bad idea to say, well, there's this approach and that approach. But on the unit where I worked, this is how we manage this problem. Okay, so that is subtly more sort of, that's subtly stronger than this is my opinion. What you're saying is, where I worked, the person who trained me, the person who supervised me, this is what they did. So it's a little bit more, there's a bit more strength to it than this is just what I would do. It's what my trainer would do and what my supervisors would do. And the examiner might think, well, I don't really think that's a good idea, but that's what some people do. And that maybe help you a little bit. And if you're feeling really, really confident, and this might be slightly overconfident, you can say, well, I've worked on 2 units, and this is what we did on 1 unit, and this is what we did on another unit. And then the examiner is going to say, well, what are you going to do? So you'll have to sort of put that forward. But you can sort of, if you introduce into the discussion, on the unit where I work, this is how we manage this sort of problem. That can be helpful. If you're really just to try and ground yourself in being safe. And sometimes the answer is, I would refer to a bone tumor service, or something like that. Tumors come up quite often, and the examiner wants you to know that you in the real world, that you're not going to sort of sit on this problem and not refer it to a bone tumor service for a bone tumor opinion. Okay, so your threshold is pretty low, but and it's good to put that into the conversation. In a practical situation, I would look at this imaging and I would discuss it at an MDT meeting, and I would specifically want to know whether it needs to be discussed with a regional tumor or a national tumor service. So you're putting, you've been in that situation before, and the examiner might then say, well, okay, you are the regional tumor service. How are you going to respond to this colleague who's referred you this bone cyst? How are you going to manage it, so to speak? I mean, it sounds as though they're making, very few of us are going to be bone tumor specialists, because it's a very niche sort of area. But it's a good way of the examiners sort of testing your knowledge a little bit. But the point I would make is, come back to the practical situation. In a practical, on a day-to-day basis, on my unit, this is how we would manage this patient, whether it means referring on to another unit for good reasons or getting another opinion. That shows that you're not going to sort of, there's a fine line between having confidence to deal with problems which you're expected to deal with yourself as a day 1 consultant. But as a day 1 consultant, you're also expected to say, well, I know what this is, and I know I haven't got the expertise to fix it or to do it. So I'm going to do the right thing, and I'm going to get an opinion from somebody who's got the expertise. And there's sort of no shame in that. But then you can make that point and then say, well, these are the principles of treatment of this sort of more difficult condition. But make the point that in practice, you're not going to take this on yourself as a day 1 consultant. You can see that this is something that needs somebody else to have a look at. That means you're safe. Yeah. So being safe is really important.
Absolutely. We try to emphasize the same. Be safe, MDT approach is the way forward in the exam. We have one more question also. It's all tricky questions.
That's okay.
And so Muhammad Gawadi asked, he's worried that if he gets the first question wrong,
yeah,
that's going to leave a wrong impression for the whole of the station and probably the whole of the table with both examiners. If you get the first question, he's worried about the first impression, and if he answers the first question wrong, leaving a bad impression. Is that correct? Is there a way to come back from that, or?
But there is a way back. I've seen candidates handle the first question badly, and then handle the second and third questions well. And the examiner's got to move on. He can't just go on. He cannot just ask you one question. He's got to, he's got 5 minutes, and he's going to ask you a second question. So they should, they try and ask a sort of a question which is based upon an everyday, like supracondylar fractures in children, tendon sheath infections in hands, things that you would sort of expect to sort of come across, fairly often. And that first question, you might not think it's a particularly easy question, but the examiner's probably, their starter question. So try and be really confident in that first question. Think, good day, thanks for asking me about, tendon sheath infections. This is how you manage tendon sheath infections. Thanks for asking me about supracondylar fractures. I'm just going to talk about this until, and the complications and go from there. So yeah, try and be more confident than you sort of feel deep down in your response to the first question. The examiners, will give you credit for the second and third questions, but I think it's just a human thing in a way that, if people perform well in the, conversely, if you perform well in the first question, then you can sort of, you're off on a good footing with the second question. So it's not impossible to make up the ground. So every time they bowl you a new ball, think, I'm going to hit this for 6. I'm going to try and score a 7 for this particular question. I'm going to think about the literature in the back of my mind. I'm going to try and introduce that at the end of the sort of the conversation, even if there's not a particularly obvious place to put it in. I'm going to try and force this my knowledge about both recommendations and the literature that I've read. So sorry to go on about that.
No, it's
the examiner would have cut me up a long time before me going on like that. They would have stopped me. They would have put up their hand and said, stop.
Move on. We have one more question, Mr. Marshall.
Sorry,
now, there are some examiners. Sorry, Shwan.
My apologies. Just to reinforce what Dr. Marshall was saying, if you've done really badly, and it's 5 minutes per topic. If you've done really badly on the very first topic, the examiners are not allowed to take that impression to the next question they're going to ask you. So they've put it behind them. Maybe they're all human, of course. They might have something in the back of their mind, but they've put it behind them. You need to put it behind you. You need to develop the technique of, this is a new question. This is a new chance. This is your chance to get a 7 to make up for the 5 on the last question. So don't be despondent. Just put it down, take a deep breath, and focus on the next question. That you need to develop that technique as well. So don't panic about getting a question bad in the first time.
Yeah, I would completely echo that, Swan. You've got to sort of, this is a new question. I'm going to go and, I'm going for this question as though it's, I've forgotten the previous question already. I'm going for this new question. You've got to have that mindset. It's not easy. I know it's really quite a high stressful, high stakes exam, but that sort of approach is the way to do it, I'm sure.
Absolutely. Yeah, it's not easy, but it's the way to pass this exam. Now, there are...
I have one question for us, if you don't mind.
Yeah. Yes, we have some more questions. Go ahead, Hani. What's your question?
So sometimes, Mr. Marshall, the candidate is speaks faster than he thinks.
Yeah.
So if he said like a stupid answer and they want to stop and rephrase his answer again, what do you recommend for him to do or to say?
Yeah, some people do say things that they realize are not correct. And if you do do that, you can correct yourself. And I would suggest, if you say, well, I've said, you know, I said something that was incorrect and I didn't realize, you know, it just came out because I was, you know, like a little bit nervous, I suppose. You can correct yourself. And the examiner will have noticed if you said something wrong, because these are questions that they've asked a lot of times before. So they sort of know what people are going to say. And they've had a number of sort of candidates who they've already asked that question to. So they have, you know, favorite questions. So if you think, well, I did say something wrong there, you know, it was a minute ago and I said something wrong, you know, I just remember that I said what I said at the beginning. I just want to clarify that you know, what I really meant to say was this. So if you do say something that you think, well, I shouldn't have said that and that was wrong, I think it's good to go back and make it clear that you realize you've said something wrong. I think it's better to do that than to hope that the examiner didn't notice it, because I think the examiner will notice it. So Firas and Schwan, the faculty, do they want to comment on that one?
Yeah, absolutely.
Yeah.
If you've made something, you can actually watch the other person who's not asking you the questions. And I often say that if that other person just suddenly sits forward or puts his head up, you've more often than not said something that you shouldn't have said. So take a moment to think about what you said.
Yeah.
Don't overthink these things, but if you feel that something is wrong, take a deep breath. Again, I can't emphasize this enough. Rehash what you said and say, I misspoke, I meant X, Y, and Z. But waking the bear, which is often who I call the other examiner, is a bad sign.
You could always say, I misunderstood the question and I answered wrongly, and I would like to withdraw that and restart. That's definitely, the examiner will even acknowledge this, and they will sort of respect the candidate that's you know, admitted their mistakes rather than just continue to bluff around and hope the examiners will haven't noticed. So
yeah,
Mr. Mash, one more question, if you don't mind.
Yeah.
So there are some examiners who have a reputation of being difficult and they fail everyone. So candidates can go to that station and see Mr. So-and-so and think, oh, I'm failing this station, definitely. He fails everyone. He failed me last time, he failed my friends. And how true is that? Is there some truth in that? How true it is? What's the best way a candidate can approach such a situation?
Yeah, I don't think there's much truth in it. I think the protocol for sort of assessing examiners don't do examine because they like failing people. They sort of do it because it's a sort of part of their own development, and they feel it's a good service to do for training. And they really just want to give somebody an accurate, they want to get the best out of the candidate. That was going to be my final point. I, as an examiner, or I, as an interviewer, want to get the best out of you. I don't want to get the worst out of you. I want to get the best out of you. So, you want to give me your best, and I want to get the best out of you so that I can give you, what I think is a good score. I mean, we've all in our past, I suppose, had bad examiners examine us and, give us a lecture on something when we've said something which we didn't perhaps mean to say. But the vetting process for examiners and the sort of quality assurance, if you like, of examiners is such that, I think those days are over. Everybody can sort of think, oh, he's so-and-so, he does this, but we all get at the end of our examinations, we get a sort of a breakdown of our scoring, and you should try and, you shouldn't be an outlier, like in anything in orthopedics. Don't be an outlier. So you don't want to be an outlier where you're too much of a dove, dove is somebody who's basically gives the marks too high, and then the hawk is the one who gives the marks too low. So at the end of the examination sort of session, all the examiners get their own marks fed back to them, and you should sort of look and make sure that you're not sort of, that you want to be sort of scoring, like everybody else is scoring. And if you're scoring too high or too low, you've got to ask yourself, why am I scoring too high or too low? And I do honestly feel that people who are examiners do really want to get the best out of the candidate and to sort of help them through, which is a really tough exam. So yeah, maybe I'm biased because I was an examiner, but but I've also, I do remember being examined, and you do sort of think, this examiner is out to get me for some reason. But I think a lot of that is in your mind. Honestly, I do think it is in your mind, and I think they just want to assess you and give you a fair sort of a fair assessment. I really would say that. Thank you, Mr. Mayor. I think that's thank you for explaining this. That will put a lot of mind at rest, and especially those going for the exams. Your words are very reassuring on that aspect. Do you have time for one more question? Yeah. If you've got a couple, please do. Look, so Muhammad Javid asked if you are unfortunate in that bad situation when you got the first question wrong, the question that's only maybe starting or competency question, you got it wrong, and the examiner then, or you say, I have no clue about this topic, and the examiner then change the topic or change the question completely, or does that mean it's a fail? Well, they will probably not change the topic completely. They will give you sort of more prompts, really. That's often what they, if you're struggling, in order to get the best out of a candidate, you give them a prompt, sort of what, so supracondylar fractures and an absent pulse, what would you do with that sort of situation? And a good candidate would be able to sort of say, this is what I do, and this is what I've done. It's quite okay in the exam to say, I have had a case like this which I managed, and this is what I did, or this is what I did with my supervisor. But if you're struggling, the examiner usually gives you a little bit of a prompt, and then just like any other sort of difficult sort of situation, you can sort of try and maybe go back to first principles, or you can try and go back to, in a practical situation, in a work situation, this is how I would answer this problem. So you can sort of go back to that point. And I think if the examiner chooses to move on, you've got to move on too. I mean, you don't really have a choice, but they give you quite a bit of prompting, I think, before they move on. And if in that situation, would this candidate still have a chance to pass that question, or? I think it depends how much prompting they need. I think, to sort of get to get a sort of bad fail, if you like, to get a 4, you probably, most examiners would feel, well, this candidate was unsafe. He was not, he or she wouldn't be safe to be a day one consultant. So I think for me, that was often my justification for giving 4. And you may say, well, there's a certain core knowledge that you need to be a day one consultant. And if you don't have that knowledge at your fingertips, I mean, knowledge in the world today is on your phone, isn't it? Or every single bit of knowledge in the world is on your phone. So there's a certain core knowledge that you've got to have inside your head, particularly for the, from the examination point of view. So yes, the examiner should give you prompts, but I guess if you're really struggling, to go back to, if it's sort of basic science or, those sort of things, go back to first principles. These are the principles. This is what I know about this topic. Even if it's not exactly the question that I've been asked, this is what I know about this topic. So I would, try your best. I think being silent and saying, I'm sorry, I don't know anything about this, it's a difficult one for the examiner to sort of, they can't help you through that. If you've sort of given them that, I don't know anything about this. That's not a good way forward, but just tell them what you do know, even if it's sort of not exactly what they've asked for. I mean, they will then sort of maybe sort of pull you up on that a little bit, but I think it is probably better to give some knowledge which you know to be sort of true, if you like, or good knowledge, even if it's not exactly what they've asked for. And then they will probably prompt you and ask you and probe and see where exactly where your level of knowledge is. I don't know, what do you think about that, Shwan and Firas?
I won't. So I would never advise someone to just say, I don't know something. If you don't know something, you really don't know, and it's at a higher level, that's fine. You can say it. If you're already at 7 or 8 and you've done really well in the last minute, I don't know is a sign of integrity in a lot of ways when they're asking you about that particular literature in Journal of Hand from 1947 or whatever. But if you are on the very first question and you say, I don't know, the examiner can't do anything for you. What you can say is if you don't know the answer they're asking you, you can say, please, could you rephrase? I'm not sure I understand the question. That gives the examiner a chance to prompt and rephrase and maybe add an extra little bit of information onto the question that he was asking you. And it would be considered a prompt, but it could pull you into the situation where you can answer the question much easier.
I think that's a very good point, Juan. Can you rephrase it? Or even going back to even if you're not sure of the question, repeating the question back to the examiner in a slightly different way. Is this what you want me to talk about? So that sort of clarification is good. Yes, yeah. Or can you rephrase? Is it possible for you to sort of to ask that question and to rephrase it is a reasonable thing to do? But I would always, to try your best to try and do your best with the question. Obviously, if but there are some questions, I guess, which are really difficult. But those difficult questions should come at the end rather than at the beginning. So you've really got to try the initial questions. You sort of try and put together an answer, even if if you're a bit uncomfortable with it, but try and put an answer together. That would be my suggestion.
I think, I totally agree. We've been doing this for some time, and we've seen hundreds of people who've been through the exam, and we vivaed a lot of people. I don't think I've ever seen a candidate who cannot answer the first question or say something about the first question. I think that's extremely rare situation, but maybe the advanced questions, obviously that can happen. And that not always bad thing, as Shwan said, but it'd be extremely rare. I mean, if they are not be able to talk something about the opening question, something at least, say something that's has some meaning. So just give the examiner something to hang on to and to help you. I think we can all say something about any X-rays or any topic, even if they're not going to give you anything that's you've not seen or not read in the books anyway. So I think that'll be extremely rare.
Yes,
that's not knowing to check about the first question in the table. I think all the messages we had is just echo what you said, Mr. Marshall, about you have to redeem yourself and be confident, and try to gather yourself up. And it's probably the examiners will, have a lot of respect to candidates who maybe has been put off a little bit to start with by not answering well, and then he picked up himself up and for the rest of the questions. I think they will definitely respect that.
I think that you're not sunk. If you find the first question difficult, do your best, and then think, deep breath. This is the second question. I'm going to make up for it. I'm going to make up for that first question. I'm going to really show them. So you have to have that sort of approach, which is difficult, but you've got to. I'm sure that's a way to score marks and to get through it. I'm sure that's the way.
Absolutely.
Well, that's wonderful. I think, does anyone else of the mentors have any questions to Mr. Marshall while he is here. I know Mr. Marshall has another meeting to go to. I don't want to hold you back from that meeting, but
actually, Mr. Marshall, just quick question, if you don't mind. If a candidate demonstrates unsafe, what you would consider unsafe, level 4, does that carry on to the other, to the rest of the exam?
No, you'll get the there's sort of the philosophy of a killer question. You know that the pediatric surgeons sit alongside the hand surgeons, and the idea of a killer question is it's a bad concept, really, because sometimes what the hand surgeon might think is a sort of killer question, the pediatric surgeon think, well, I don't think that's really fair to sort of ask that make that a killer question. And similar, you know, in pediatrics, you know, you might say, well, that was a really bad thing to say, but the hand surgeon might think, well, I don't think it was that bad, you know. So the concept of a killer question to sort of completely fail somebody for everything, and you that's not the way it works. I mean, you may get a 4 at one point, but you can make up for a 4. You can make up for a 4. So, you know, that's why the philosophy of, you know, I'm going to get a 7 out of every single question they ask me, because, you know, life, sometimes you don't quite get a 7 every single time, but you need to aim for a good pass for every single question, because there'll be 1 or 2 questions where you may be a little bit borderline, and that's just the nature of exams and questions. But to have that mindset that every single ball that they bowl to me, I'm gonna try and get a good pass from this. I'm going to try and get a 7 from this, and I'm going to do that.
I think the question maybe Chuan trying to get to, or you know, if someone is really said something really unsafe in the exam, let's say they missed a terribly displaced cervical fracture dislocation and the patient dies from respiratory arrest or something, is there a decision made collectively that this candidate, no matter how well he does in the other stations, he killed the patient, and therefore he's not safe to pass the exam? Is there such a thing?
No. Well, I can only speak on the basis of my experience of an examiner sort of 5 years ago, Ferris, but no, there isn't. You cannot sort of play that sort of card and say, you know, I've failed this candidate completely. You can give them a 4, and it is a little, you know, you've got to score well on your other questions if you want to overcome a 4, but you cannot be sort of completely wiped out because you know, somebody thinks you've done something that's unsafe. That doesn't work. So yes, you can still make it up if you know you felt you've said something that's unsafe. It's obviously, don't try not to say anything that's unsafe. That is quite an important message, because we want people who are safe, even if they, you know, maybe their knowledge is not sort of, you know, really on top of everything, but we want people who are safe and who will be able to recognize maybe their own limitations, where they need to ask for help in a practical situation. But we also want to make sure that they can function and they have the competences and capabilities to work as a day 1 consultant. I don't want to sort of, I definitely wouldn't want to put people under the impression that that there is a way of that you can be just sort of eliminated because you make one bad question. You've still got time to make things up. So that the idea, the mindset, if you like, of I'm going to put that behind me, I'm just going to focus on what's coming at me now, is definitely the way to approach things.
One more question. Given that you have 12 scoring opportunities in a single viva, 2 examiners, can you still compensate for 1 or 2 4s?
Yes, you can. I mean, as long as when all the numbers add up, you've got, you know, you've crossed the line, you've got a borderline pass, and you've passed. So you can make it up. You can make up for it.
I
Yeah.
don't disagree that you can definitely make up for a single 4, maybe 2. But if you've got 3 4s, I think given the standard that they pass to get a 6 and how hard you have to work to get a 7. So if you get 6 on every table and every Viva question, that's a pass of the exam.
Yeah.
If you get 1 5, you need to get a 7.
Yeah.
So
That is right, and that is why I know I keep saying it, but you're aiming for a 7. Aim for a 7 for every single question, because you won't get a 7 for every single question, but if you do, it'll help to make up for the odd, the odd 5 that you might collect. So aim for a 7.
But it is very difficult for so 4, you need 2 7s to make up for a 4. It really gets more and more difficult. I'm not saying it's impossible. I agree with Dr. Marshall. It's not impossible. You should never give up.
Yeah.
But don't accept a 4. Try and get a minimum of 5.
No, try not to.
There is one more question that we get very often asked, is that candidate, there are 2 examiners in a table, and there is one examiner asking questions. The other examiner is very busy looking at a piece of paper and writing letters and numbers and codes and stuff. And some candidates, they have reported that been looking at that second examiner, what they're writing, and they see them write 5 or 6 or 7 or 8 or whatever. Is that correct, or is that just?
Well, not in my experience. I mean, you do make notes on the candidates, because as you say, the other examiner is scoring as well, but that shouldn't be visible to the candidate. So that would be bad examining for it to be visible. But from the point of view of the candidate, obviously, do your best to focus on the examiner. You may get we mentioned earlier, the subtle movements of the non-examining examiner, who might lean forward or lean back. Those sort of movements without any facial expression, you might sort of pick up little things from that, but don't try and focus on the examiner that's asking you the questions.
And from your experience as examiner, I don't know if you got involved in the marking, but obviously in the sort of overall marking, but is it common for, I mean, for someone to score a 4 and to pass the exam, theoretically, they probably have to score lots of 7s or an 8. I presume that's rare. I mean, would someone who scored 4 in a question be able to score lots of 7s or 8s to compensate? Is that common?
Well, the honest answer, Firas, is I don't, I wasn't involved in that sort of, in those sort of scenarios, but it would be, I mean, it's not impossible to score a 4 and then to make up for it. So that is the message I would pass on. And it's just a simple mathematical formula. You've got to score a certain number of high marks to compensate for a low mark. It's just a mathematical formula.
Lovely. So, Mr. Marshall, I don't want to be holding you back.
Well,
it's been very kind. You came at such a short notice out of your busy schedule, and you squeezed us in your daily program.
No, it's a pleasure. I hope you have a good Viva session now, and thank you for all your participants for sort of your questions. And guys, I know it's a really tough exam, but it is an exam that it is passable. I know there's lots. It's always difficult when you're at the wrong side of the hill and you think I'll never get up there, but you've got to have the mindset. Yes, I can do this. I can get through this. And every single question they ask you, I'm going to try and get a good mark on this. I'm going to try and get a 7. I'm going to think about the literature. I'm going to think about what the BOAST recommendations are, and I'm going to try and bring that in at the end of the conversation, because I just want to try and tip the examiner to giving me tip me from a 6 to a 7. Guys, thank you very much for inviting me.
Thank you. Thank you so much for the short notice. Brilliant talk, Dr. Marshall. Thank you.
Yeah, it's really good. hope you have a good rest of the session, and I'll have a chat with Nicola tomorrow. Thank you very much.
Thank you indeed,
Okay.
Mr. Marshall. Thank you, and we hope to see you again. We really enjoyed it. And
Okay, well, yeah. It's been great. It's great to be here. Thank you very much.
Good night.
Cheers, Firas. Thanks.
Good night.
Bye-bye now. Bye-bye.
Thank you.